in scientific journals and chapters in textbooks, and is currently the editor of our journal, the Nigerian Journal of Dermatology, and she's the head of the Dermatology and Genitourinary Medicine Unit at the Lagos University Teaching Hospital. So without much further ado, I'd like to hand over to the moderator, Professor Olushola Ayalowo, to take over the proceedings for the day. Thank you.
Good evening, everyone. You're welcome to the psoriasis community webinar to mark the Psoriasis Awareness Month. And I would like to thank Dr. Kikube and the NAD ESCO and the webinar committee for graciously allowing us to have this community-based webinar. And we hope to reach out to ourselves and our colleagues and then other doctors, pharmacists, nurses, family physicians, medical officers, and talk about psoriasis. Okay, so well, I don't know whether Dr. Ibekwe has she been able to join us? We'll be starting with Dr. Ibekwe, who should be talking to us on, okay, we'll be introducing the topic and getting us into the topic. So Dr. Ibekwe is an associate professor. Can you hear me? Hello?
Yes, we can hear you loud and clear.
Okay, so Dr. Ibekwe is an associate professor at the University of Abuja College of Health Sciences. She's an astute clinical researcher and has worked along with us with the psoriasis registry. So she will be talking to the introduction and epidemiology of psoriasis. Dr. Ibekwe, you are welcome to start. Thank you. Dr. Ibekwe. Dr. Ibekwe, are you with us? I think I saw her. So can you share your slide, please? Okay. So I know she was in the traffic, but I've seen her join us now. Okay, so so that we won't keep us waiting, I'll call on Dr. Folakemi Cole to take her session. Okay, so she's and also a consultant physician and dermatologist at the Lagos State University Teaching Hospital. And she is an associate lecturer at the Lagos State University College of Medicine. She's a skin public health advocate on social media, and she's also working actively with patients, caregivers in education on albinism, bleaching, and skin entities, and that includes psoriasis. So Dr. Folakemi, can you Cole Adefe, can you just share the slides for us? Thank you. So Dr. Ibekwe will let me know when she is able to join present. Maybe she'll present after.
Good evening.
Dr.
Good evening, everyone. Good evening, Mr. President, and the esteemed members of NAD, the community, everyone on the call and on YouTube Live. Thank you very much for joining our webinar. Okay, Dr. Ibekwe is online at the moment now, so we'll just have her presentation first, and then we'll move to the next Dr. Ebekwe.
Yeah, good evening, everyone. And sorry for all the mix-up. Okay, so as was introduced, I will be introducing the topic psoriasis, which is the main reason we're all gathered. So I'll be answering the question, what is psoriasis? So looking at this feature, so psoriasis is a group of inflammatory and proliferative conditions of the skin that is associated with systemic manifestations. Basically, it presents with red, scaly, well-demarcated, indurated plaques that are present particularly over the extensor surfaces of the body and scalp. It has a heterogeneous morphology. The sites that it affects also differs, and the natural history. It's the age of onset also differs, duration and precipitating factors. And some of these features, and Dr. Cole will be dwelling on it. But generally, we just believe that it's a combination of both genetic and environmental factors that play a critical role in the etiopathogenesis. When you look at the epidemiology, it's seen all over the world, but the prevalence, that's the number of patients that have this disorder differ widely. It's more in the areas that are more away from the center of the world. So it's more, you have higher prevalence in countries like Norway and quite low in Africa. For us, within the African continent, from the studies available, you see that we have more people with psoriasis in the southern part of Africa and very few in West African countries. We don't know if this is because of poor reporting, but that is what we have right now. We have two peaks of incidence. Those that are younger, the psoriasis starts at the age between 16 and 22 years, and those that start at an older age of 60 years. We realize that those that have psoriasis at a younger age are quite few. That's the percentage are lower than those that start at an older age. The affectation is equal between males and female, but we have realized that males tend to have more severe disorder. So this is just giving us an idea of the prevalence. If you could see that the countries that are closer to the poles have higher prevalence than those in the center. Sorry. Please, let me stop this slide. Sorry, I have a wrong slide. Just 1 minute, please. All right, so because of loss of time constraints, basically what is more in psoriasis is the fact that the cells are multiplying faster than usual, and so the scales tend to build up on the skin. I had a slide where I could show you different presentations of psoriasis that at least I've seen so far. Unfortunately, my slide is not coming up. So I'm going to end the presentation here, and hopefully Dr. Cole will give more details. Thank you.
So thank you, Dr. Ebekwe. You might, if you have time, you might show your slide later. Dr. Folakemi Kolade, can you present your so I've introduced her, and I said that she's a very vibrant public health enthusiast on social media. And then she's a lecturer at the she's an associate lecturer at the LASUCOM and a consultant physician and dermatologist at LASUF. Okay. She
Good evening once again. I hope you can see the slides.
okay.
Hello.
Yes, I can say it. Yes.
Okay. So thank you everyone, and thank you, Dr. Ibekwe, for the introduction, talking about psoriasis, what it is, and how common it is in our environment. I'm going to be talking about, and the overview of clinical features. I'm going to be talking about a bit about what causes psoriasis, kind of the what we call pathophysiology, as well as classification types of psoriasis. And so we're starting from the pathophysiology of which is essentially how it happens. Psoriasis is a chronic immune-mediated inflammatory condition, and it affects the skin, joints, nails, other organs and systems in the body, but primarily the skin, joints, and the nails. Now, the pathophysiology involves a complex interaction of genetic factors, the immune system malfunction, or what we call immune dysregulation, and environmental triggers. And these result in abnormal skin cell growth, what we call keratinocytes, as well as recurrent inflammation. And that's why people with psoriasis tend to have flares. So it waxes and wanes. Now, the three pathophysiologic or pathogenetic factors I mentioned is environmental triggers include things like trauma, stress, and medications, infections, viral infections, bacterial infections. Then we have genetic predisposition. There are some specific genes that are associated with psoriasis. There's the HLA-CW6 and gene variant and several other genes that have been linked to psoriasis. Now, immune dysregulation means that the immune system begins to produce abnormal amount of cytokines. These are chemicals and molecules that send wrong signals to the immune system and make these skin cells or the keratinocytes to proliferate excessively, causing chronic inflammation. I'm trying to use very simple English because I realize that we don't have just medical doctors here or dermatologists, but this excessive keratinocyte proliferation and chronic inflammation is what leads to the clinical symptoms. So I've mentioned there are genes associated with this, then the environmental triggers like stress, infection, injuries, and these can trigger psoriasis or worsen psoriasis in genetically susceptible individuals, people who have genetic predisposition or specific genes or alleles that have been associated with psoriasis. Also, so going more deeply into this pathophysiology, the white blood cell, there are some activated white blood cells known as the T lymphocyte, particularly the T helper 17, that get into the skin in response to some of these environmental triggers we mentioned. And they release some inflammatory molecules like the interleukin 17, 22, and TNF alpha. And these cytokines activate the skin cells to begin to produce more of these inflammatory molecules and lead to excess proliferation of the skin cells. So the skin, and this can result in skin barrier dysfunction. So in response to these inflammatory molecules, the skin cells begin to proliferate excessively and rapidly without maturing properly. And this is what leads to the thickening and the scaling of the skin, what we call epidermal hyperplasia, and the characteristic scaly plaques that we see with psoriasis. And it can also cause new blood vessel formation, which is why in many cases psoriasis plaques in lighter skin types tend to be reddish or erythematous. In darker skin, you may not appreciate it so much, but in some cases you still see the redness. And sometimes when people scratch or peel the skin lesions of psoriasis, it tends to have this tiny pinpoint bleeding because of the excess blood vessel formation that is associated with the condition. So I'm going to then talk about the classification. Now, there are various types of psoriasis can be classified into several types. You have the plaque psoriasis or psoriasis vulgaris, which is the most common and is what occurs in 80 to 90% of people with psoriasis. There's also guttate psoriasis, which presents as small drop-like, raindrop-like, and multiple lesions. Usually it occurs after upper respiratory tract infection. Inverse psoriasis is called inverse because plaque psoriasis tends to affect the extensor surfaces and the extremities and the trunk. But in contrast, inverse psoriasis affects the skin fold. So you find it in the groin, in the armpits, under the breasts, in areas where you wouldn't first think of psoriasis, and is often, thought to be something else like a fungal skin infection. Pustular psoriasis is where it developed sterile pustules of pus-filled skin lesions, usually all over the skin or generalized, and this can also occur after the use of steroids with psoriasis or systemic steroids, and in some cases it just occurs for unknown reasons. Now, nail psoriasis is also something that is commonly thought to be or misdiagnosed as fungal nail infection, and it's associated with nail pitting. I will look at pictures of this, onycholysis, that's lifting up of the nail from the nail bed and thickening of the nail. And then scalp psoriasis is very common. Most commonly, people think it's like a stubborn dandruff or a very severe dandruff, but I'll show pictures of that as well. And then psoriasis can be palmoplantar, meaning affecting the hands and the feet. And then it can also be an erythrodermic psoriasis, which is something that affects the whole body and, is quite serious, is a more severe form. And then psoriasis can affect the joints as well and cause what we call psoriatic arthritis. So just looking at some pictures of some of these various types of psoriasis, this is the plaque psoriasis, which causes silvery, scaly, well-demarcated plaques on the trunk and extensor surfaces. As you can see, this is the trunk on the back, this is on the leg, and you can see these grayish or silvery scales and well-demarcated. You can see the plaques. If you look here, you can see some tiny pinpoint bleeding and there's some little redness. In us dark-skinned people, it may not be so red, but you can still appreciate that there's some underlying redness or erythema, and these are plaques as well. So that's what plaque psoriasis looks like. Now, inverse psoriasis, as you see under the breast, it may look reddish and may occur from time to time, often misdiagnosed as fungal or erythrasma, but you treat, with the regular antifungals, it doesn't go away, it doesn't get better, then you may want to consider inverse psoriasis. Palmoplantar psoriasis tends to affect the palms and the soles of the feet and can be quite debilitating because the person is unable to use their hands or able to walk properly. And that's what that looks like. Now we have the pustular psoriasis, which is tiny generalized pustules that can be generalized or localized. And then this is what we call guttate psoriasis. So you have raindrop-like appearances on, usually on the trunk. That's where it occurs. Scalp psoriasis, as you can see in this picture, you have thick, scaly plaques on the scalp, and this can actually be thought to be dandruff by a lot of people, red scaly plaques, but they'll tell you when they try to peel it, it tends to bleed. And that's something that would make you think about psoriasis, and the scaling and the plaques are quite thick, much thicker than the usual dandruff. Nail psoriasis is often misdiagnosed, and you can have nail pitting, ridges on the nails. The nails can become deformed, and there can be like a reddish patch on the nails, as well as thickening and crumbling of the nails. So, and it usually affects all the nails. So where you have people having multiple nail involvement with any of these lesions, nail psoriasis also is a possibility. It's not always fungal nail infection. And psoriatic arthritis affects about 10 to 30% of those with skin symptoms. And some people even have arthritis without skin symptoms. I know Dr. Olaoshibika will be talking a lot more about that. And it usually affects the hands and the feet and occasionally the large joints. They have this kind of sausage fingers, and sometimes can have severe deformity of the joints as well. Erythrodermic psoriasis usually affects the entire body surface area, at least 80%, and is associated with scaling and desquamation. That's the skin is just scaling and peeling. And you can see in this picture, patient has widespread affectation of the skin and scaling and redness. That's the erythroderma. And the underlying cause, when you do a biopsy, you find that it has features of psoriasis. It occurs often in immune-challenged patients. It can occur in patients with HIV, and it can just occur in patients with severe, uncontrolled, or improperly treated psoriasis, and it's a medical emergency, often requiring admission and intensive care. So there are other things that can look like psoriasis but are not, and many times people misdiagnose psoriasis as fungal infections, that's tinea. Also, atopic dermatitis or eczema can mimic psoriasis, particularly in the hands and the feet. Seborrheic dermatitis also is something else that can be considered to be psoriasis, and there are several other conditions, as we can see here. The different types or classifications of psoriasis can have different other possibilities, and that's why it's important to seek expert review to be able to rule out any of these other differential diagnosis of psoriasis. And so my take-home point is that psoriasis is an autoimmune or immune-mediated chronic systemic condition. And in the pathophysiology, it is caused by a complex interplay of genetic factors, environmental factors, and immune dysfunction. There are multiple clinical types. Plaque psoriasis is the most common, and there are other types like buttate psoriasis, inverse psoriasis, scalp psoriasis, nail psoriasis, and erythrodermic psoriasis and psoriatic arthritis. Psoriasis may look like other skin or nail conditions, so it's important for expert review to be done so that appropriate diagnosis and treatment is achieved. Thank you very much for listening, and I'll move on to the next presentation. The next presenter. Thank you.
So I'd like to introduce the next presenter, Dr. Olaoshibikon. Akim Olaoshibikon is a consultant rheumatologist at the Lagos State University Teaching Hospital and a senior lecturer. He works with us on psoriasis and also on lupus erythematosus. Dr. Olaoshibikon, you're welcome to start your presentation. Dr. Olaoshibikon, you're welcome to start.
Okay, yeah. Good evening, Professor, consultants, patients, and all stakeholders. Am I audible, please?
Yes.
Okay. And I guess my slides are also visible. So I just want to, please give me a few minutes to start from the beginning. Thank you. So yes, good evening, everyone. As introduced, my name is Dr. Olaoshibikon. I'm a rheumatologist with very special interest in psoriasis and other autoimmune skin disease as well. Dr. Cole she has made my work so very easy, but it's just to talk about joint perspective as well as multisystemic perspective of psoriasis as a systemic autoimmune disease. Now, as a way of background information, more than 500 million people all over the world, live with various forms of arthritis. So arthritis is not just one disease. It is a manifestation of about 100 diseases that can present with joint manifestation. So arthritis can be a window to internal organs or systemic disease. Psoriatic arthritis, meaning that arthritis associated with psoriasis, is among 5 leading causes of arthritis worldwide. We know that the commonest cause of arthritis all over the world is osteoarthritis, followed by rheumatoid arthritis, followed by gouty arthritis. But psoriatic arthritis is among the 5 leading causes of arthritis. And why do we need to study psoriatic arthritis? If we don't understand it, we don't study it, and we don't diagnose it on time, is a cause of, joint damage, restriction of function, as well as disability. And sometimes it can even lead to cardiovascular disease, which is heart attack or even stroke. Now, psoriatic arthritis affects 112 persons per 100,000 adults worldwide. Am I not?
Okay.
No problem. Worldwide. And in Nigeria, in our own study in Nigeria, about 0.5 about 2.5 to 0.8%. Can you help me mute?
Where your house go, sir, madam?
Can you help us mute those people? They are interrupting my presentation, please. Okay, thank you. In Nigerian studies, about 0.5 they admit, let me limit. In Nigerian studies, about 0.5 to 0.8% of our patients in rheumatology clinic had psoriatic arthritis. But in a dermatology clinic, about 20% of patients was found to have psoriatic arthritis. That's a study by Ajibade et al.
When I enter,
1 in 3 persons with psoriasis actually have been found to have psoriatic arthritis. Next slide. Now, as I said earlier, psoriasis is now being termed psoriatic disease because it is an autoimmune disease. And there are 3 components to that. There is psoriasis, there is psoriatic arthritis, there is vascular inflammation, which is widespread vascular inflammation, meaning that any organs or system can be affected by psoriasis. Now, what are the domains of psoriatic arthritis? Psoriasis or psoriatic arthritis can affect the digestive system, or what is called gastrointestinal system. That can present with inflammatory bowel disease, namely Crohn's disease and ulcerative colitis. And patients with that manifestation may have lower tummy pain, bloody stools, or what we call hematochezia, some diarrhea, stoolings, those are or even, feces with mucus. Those are the common symptoms of Of inflammatory bowel disease. Now, patients with psoriasis may also have red eyes, painful red eyes, which we call uveitis. And so they may have photophobia. That means when they want to, they are afraid of sighting lights, They may also have painful eyes and red eyes. Patients with psoriasis or psoriatic can also develop, low back pain, which usually worse in the morning or worse at night. And sometimes they may have difficulty bending down or even buttock pain, which is also called psoriatic spondyloarthritis. Okay. Now, patients with psoriasis, as Dr. Cole said, they can develop swollen joints or swollen hands, swollen feet, which is called dactylitis. They may what we call it sausage digits. That is when you look at sausage, the way sausage appear, the finger may be swollen just like sausage, or the feet may be swollen like sausage, and painful. Patients with psoriasis can also develop pains at a particular spot in the body, such as the heel. They may have heel pain under their heels. They may have knee pains or even chest pain, depending on where the tendons or ligament attach. Now, psoriatic arthritis, in most cases, occur after developing psoriasis. That is like 7 to 8 years. Generally, after you have psoriasis, the patient may develop psoriatic arthritis. However, psoriasis can occur together with psoriatic arthritis in 20%. And rarely, arthritis may develop before the onset of psoriasis. So for the family physician or GPs among us, psoriasis may actually, you may not even see the patch. It may just be the joint manifestation that will present to you, or even nail manifestation of psoriasis. Now, there are other associations of psoriasis. Psoriasis is associated with metabolic syndrome, okay, which include hypertension, diabetes, obesity, high cholesterol, hyperuricemia, cardiovascular disease, which can be heart attack or stroke, depression, anxiety, lack of social integration, lack of, the osteoporosis and gout. So there's a study that showed that 55% of psoriasis patients has 3 or more comorbidities. So when we are evaluating psoriasis patients, ensure that you also look for these comorbidities. So who are those at risk of developing psoriatic arthritis? A patient with psoriasis, but with severe psoriasis, as evidenced by, PASI score, or maybe widespread psoriasis. Maybe you have psoriatic patch in major surface area of the body. Those ones, they are more likely to develop psoriatic arthritis. So as GPs or dermatologists, once patient with severe psoriasis, as evidenced by your PASI score, that person is more likely to develop psoriasis than other type. Now, patient with psoriasis with nail involvement, and that can be, when the nail is involved, dystrophic nail change, maybe the nails appear as if there is a pit on the nails, or there is a hole, or many holes inside the nails. That may also, those one with nail involvement, they also are at risk of psoriatic arthritis. Obese patients with psoriasis, people that are plus size person, they are more at risk of psoriatic arthritis. Patient with family history of psoriatic arthritis or genetic reason also more at risk. Patient that smoke a lot of cigarettes, or previous infection that trigger your immune system. Aqueous consumption. Some medications can also do that. So those are the risk factors for psoriatic arthritis. Now, for patients or even for practitioners, this tool is a validated tool that can be used in psoriasis patients to identify symptom of psoriatic arthritis early. Is a validated tools that can be used. It's recommended to be used.
Dr. Ashimeko, sorry, your slide is not moving. Okay.
Is it this currently now or is from the beginning?
Okay, so you can go on. Are you here now?
Yes, I'm here, ma.
Okay.
Is my slide visible now? Can you guys see my slides?
Yes.
So I'm talking about these training tools, which is very valuable. At least patients with psoriasis can use this tool. Even practitioners too can use it. A patient with a known psoriasis, their psoriasis, and you want to, what is called a patient management strategy or self-management strategy. There are some questions you need to ask yourself every 6 months. First question is that have you ever had swollen joints? Have you been told you had arthritis by your doctor? Have you ever had, pitings or holes on your nails, both toes or fingernails? Have you ever experienced painful heels? Or have you ever observed have you ever experienced painful swollen toes or fingers? If you have positive response to at least one of these, that means you may be eligible for further assessment by a doctor. So patient can actually use this to determine to screen for early symptoms of psoriatic arthritis before meeting the doctor. So this is recommended to be done every 6 months. That is the tool that you can actually use. Now, I don't know why this thing is not moving. Okay. Now, how do we identify psoriatic arthritis early? Because this is the window of opportunity. If you can identify psoriatic arthritis early, it can, that means there will be timely intervention with treatment and management, as well as can prevent organ damage or even internal organ manifestation and even cardiovascular death. So now the close identification and close monitoring of those at risk. Now, if you are a psoriatic patient, you need to identify your risk. Do you smoke cigarettes? Are you obese? Are your nails involved? Is the psoriasis affecting major surface area of your body? These are the questions you need to ask yourself, as I said earlier, the risk factors. If you know you are at risk of psoriatic arthritis, surely you need to you need to monitor yourself, and then the doctors too need to also monitor for all these risk factors for psoriatic arthritis, and also use that screening tools as well. Now, if you also report timely or promptly any symptom, any joint pain, you don't need to develop joint stiffness or joint swelling. Any joint pain at all, reports before joint stiffness or swelling develop. Then, although it may not be applicable to patients, but for research purpose, there are some, you can ultrasound or MRI of the joint can be done. And once the ultrasound or MRI showed evidence of synovitis in asymptomatic patients or enthesitis, that can also give you a clue that this patient may develop psoriatic later in life. Now, there's a criteria that we use, we call it CASPER criteria, to classify patients as having psoriatic arthritis. And that criteria means one is patient we have there's an entry criterion, which means that patient history of joint pain or history of painful heels, which is called enthesitis. Once patient has joint pain or back pain or painful heels or painful spine, plus 3 or more of the following I want to talk about. If patient has current psoriasis or family history of psoriasis or personal history of psoriasis, you score it. Then patient has typical psoriatic nail changes, or patient you order for the test and patient has negative rheumatoid factor, which differentiates for rheumatoid arthritis. Although we know that about 10% of psoriatic arthritis can also have positive rheumatoid factor. Then you ask for X-ray showing classical radiographic features of psoriatic arthritis, which is what you see more of a osteoproliferation more than osteodestruction that you see in rheumatoid arthritis. And then evidence of dactylitis. These are scored, and then once patient has 3 or more points, it is a definitive, for psoriatic arthritis.
The caller should come, please. You need to be rounding up now.
I'm rounding up. So not all arthritis in patients with psoriasis is psoriatic arthritis. So as a rheumatologist, we need to also look at it. They may also have comorbid overlapping other arthritis, apart from psoriatic arthritis, which we need to look for when we are evaluating our patients. Because there is a study by Ajibade et al. that found that 60% of our patients also had comorbid arthritis, apart from the psoriatic arthritis that she observed in her patients. So those are the symptoms I talk about. I just to reiterate it: joint pain, joint swelling, and all those symptoms we talk about. Now, how do we manage these patients? As well, no specific prevention measures. We should know that we can't prevent it. We can modify the risk. So once you have you just will identify patients at risk and modify that risk. So if you are obese, shed your weight. If you smoke cigarette, abstain from cigarette smoking. If you drink alcohol, abstain from alcohol. What all the risk factors, try and those ones that can modify, you modify it. There you add and appropriately for doctor identify early psoriatic arthritis.
Sorry. Dr. Lashimika, we're not hearing you, or is it my... Hello, are you still hearing him?
We're not hearing him. I think it's from his side.
From where?
Okay.
Hello?
We can hear you again. Sorry, can you round up in 1 minute?
So what are the take-home messages? Can you hear me now?
Yes. Can you go to your take-home messages and round up in 1 minute,
Yeah.
please?
Okay, so it's a lifelong multisystemic disease with no cure, but may resolve or recur throughout life. Early and prompt treatment reduces pain and complications. New treatment today are more effective, but they are expensive. There are ongoing research on novel treatment and cure. So multidisciplinary approach is important. Both all specialists that may also be involved to ensure that patient has good quality of life and reduce functional disability. Thank you.
Thank you,
Hello.
Dr. Shebiko, for that very lucid presentation. So I'll now call Professor Bolaji Otike-Odibi to give her presentation. She will be talking to the management of psoriasis in 8 minutes. Thank you. So she's a professor of medicine and dermatology at the University of Port Harcourt and University of Port Harcourt Teaching Hospital. And she's worked in various aspects of dermatology, acne, and community community projects that aims to reach out to our patients in dermatology. Thank you. You're welcome.
Good evening, consultants, fellows, doctors, patients, medical doctors, and everybody. I'm going to be talking about the management of psoriasis. Can I have the next slide, please? So this is my outline. Next slide. So we'll start with investigations. To make a diagnosis of psoriasis, we need to do a punch biopsy. That's taking part of the skin and we send it to the histopathologist that will give us a result. So what we are looking out for are changes in the epidermis, which can be thickening of the epidermis, acanthosis, thickening of the stratum corneum, which is hyperkeratosis, retention of nuclei in the stratum cornea, which is parakeratosis, which shows there is active division of the cells in psoriasis going on. Also, we can have what we call Monroe's abscesses. That's accumulation of neutrophils also in the epidermis. And then we find that there is thinning of the granular layer of the epidermis. In the dermis, we have suprapapillary thickening above the papillary layer of the dermis, and we find a good engorgement of blood vessels. We can also do dermoscopy, in which we use a dermoscope to look at the lesions of psoriasis. For white people, we expect it to be erythematous. For blacks, it might not be so erythematous or reddened. But we will see red dots, which signify red blood vessels. We'll also see scales, and we'll see yellow dots. We'll do a liver function test, especially for people that might be put on methotrexate, because methotrexate affects the liver. So we need to know the state of the liver when we start treatment. For comorbidities, like Dr. Olaushibikon has said, we will do a fasting lipid profile, looking for hyperlipidemia, chest X-ray, ECG, looking out for hypertension, electrolyte urea and creatinine, checking for renal function, a full blood count, ESR, a fasting blood sugar, checking for diabetes, uric acid for hyperuricemia, and a pregnancy test to know if our patient is pregnant before we start treatment. And also X-ray of the affected joints and spines, looking out for psoriatic arthritis. Next slide, please. So this is a diagnosis and treatment algorithm for patients with psoriasis. First of all, you see you have the clinical impression, you think of psoriasis, you do a biopsy, you get the clinical signs, you get the signs of psoriasis on the biopsy, and you now make up your mind, is it erythrodermic psoriasis, is it chronic plaque psoriasis, is it gutted psoriasis? If you think it's erythrodermic psoriasis, treatment you can use is acitretin, cyclosporin A, Puva, narrowband ultraviolet B, methotrexate, and biologics. I will talk more about these things. For gutted psoriasis, there might be no treatments, or you use narrowband ultraviolet B, topical treatment, vitamin D analogs, and topical steroids. For chronic plaque psoriasis, which is the most common one we see, we look at it if it's severe, if it's more than 30% of the body surface area. If it's moderate, less than 10% of body surface area. If it's mild, if it's greater than 10, it's moderate. If it's less than 10, it's mild. So for severe chronic plaque psoriasis and moderate chronic plaque psoriasis, you can have systemic treatment, which are the list of things there. You can have a daytime treatment center where you use modified Gockerman treatment, which is when you use holter around the patient and use a narrowband ultraviolet treatment. You can have phototherapy. That is both for severe and for moderate. You can use any of these ones, and even the mild. You can even use the topical as well. So for both severe and moderate, you can use systemic treatment, phototherapy, and topical treatment. But for mild, most of the time, you just use phototherapy and topical treatment. Next slide, please. Next slide. So pharmacological treatment, we start with topical. No, please, the slide before this. The slide before this. Okay, yes. So for topical therapy, we use for mild to moderate psoriasis, and I said even severe, we can use corticosteroids. Mild corticosteroids are normally used in the sensitive areas of the body, like the face, the skin folds, and for treating widespread patches, because we don't want much of the absorption of the steroids. For use it once daily during flares, and then alternate days and weekends during remission, because you still need to be on some sort of treatment even when they're on remission. More potent corticosteroids can be used when the lesions are more severe, when the plaques are thicker. Over time, topical corticosteroids may stop working, as with every other treatment with psoriasis. After a while, they stop working. Next slide. Next slide, please. We have vitamin D analogs. We have systemic forms of vitamin D, like calcipotriene, called Duvonex. It slows down skin cell growth. It can be used alone or in combination with topical corticosteroids for more activity. You can use topical retinoids like tazarotene, calcineurin inhibitors like tacrolimus. This calms the rash and reduces scaly buildup, and it's not intended for long-term use. Salicylic acid reduces scales. Holter also reduces scaling, itching, and inflammation. Antraline cream can also be a tar cream that helps to slow down cell growth. Next slide. Next slide. We have light therapy that we use. We have ultra UVB broadband, which is ultraviolet B broadband that you can use, which is light in the range of ultraviolet B range, in which patients are used and they go under light bulbs and it's used to target psoriasis, target the lesions of psoriasis. You also have ultraviolet B narrow band. Here the band is narrower from about 308 to 312 nanometer that of light that is used to, a patient is exposed to. And it's normally used 2 to 3 times a week until the skin improves. Then the frequency is reduced, becomes less when there is now maintenance of the lesions. You have PUVA, which is psorialine ultraviolet A radiation. Psorialine is a light sensitizing medication that the patient takes before exposing the skin to ultraviolet A light. And you have eczema laser, which is ultraviolet B light, which targets only the affected skin. Next slide. Okay. So we have oral and injectable medications, steroids. Steroids can be used as intramuscular injections, especially when you have erythrodermic psoriasis, when it's widespread, covering about 90% of the body. You have retinoids like isotretinoin, which is used more in pustular psoriasis, and it's used to decrease the production of skin cells. You have biologics. Biologics alter the immune system in a way that disrupts the disease cycle and improves symptoms and signs of the disease within weeks. In the pathophysiology of psoriasis, we saw that there were different proteins that were used and that took part in the pathophysiology. So what biologics do, they are living cells that attack the different proteins that we see, like tumor necrosis factor, interleukin. So they are blockers and inhibitors of these different proteins that are found in the pathophysiology of psoriasis, and they block them. And because of that, the disease is halted and the buildup of cells and of the skin is halted and slowed down when you use biologics. The problem with biologics is that they must be used with caution because they have serious side effects, and patients must be screened for diseases like tuberculosis, hepatitis, and other disease conditions like that. And after a while, the patient might develop resistance to a different group of biologics, like a tumor necrosis factor or interleukin inhibitors. So after a while, patients might need to change even the biologics, and they are expensive too. Next slide. Next slide. Methotrexate is an anti-metabolite that is used. It's used weekly as a single dose and decreases the production of skin cells and suppresses inflammation. It affects the liver, and so patient must be monitored. The liver must be monitored whenever the patient is on methotrexate, and even bone marrow suppression must be monitored as well. Cyclosporin A can also be used, but it cannot be used continuously for more than 1 year. Other anti-metabolites that can be used are thiol-guanine, hydroxyurea. In any situation, anyway, whatever the drug you use and whatever treatment you use for psoriasis, either systemic, phototherapy, or topical, the goal is to find the most effective way to slow down cell turnover with the fewest possible side effects. And we should realize that many times we do combination treatments. We combine either topical with systemic or with phototherapy. And that after a while, the patient might also develop resistance and stop. And so we need to look for another regimen to use for the treatment of psoriasis. We also look at comorbidities.
Please, I need to wrap up in 1 minute.
Okay. Comorbidities, patients with comorbidities will also be treated. Whatever comorbidity they have, they are sent to the appropriate specialist. Next slide. Next slide. So we also have lifestyle and home remedies. It's important for people to know their lifestyle modifications to make for psoriasis to help your life better, have a better quality of life. Taking daily baths and moisturizing yourself very well, covering affected thick plaques overnight with emollients. You stop over scratching because scratching predisposes to the development of new lesions. You avoid triggers, infections, injuries, smoking, medications like beta blockers, anti-malarials. Intense sun exposure can also cause it. And then you always eat a balanced, healthy diet in which you take vegetables, fruits, and things that will help to build up your immunity. Next slide. Next slide. So patients must need to learn to cope and have support mechanisms for this disease. They need to learn more about psoriasis, follow up their health providers' recommendations, find a support group, which we'll be talking about now. And they might need to camouflage their lesions if the lesions are too obvious and they're embarrassing them. And they need to find ways to cope with stress and reduce stress, like listening to music, praying, sleeping, traveling, watching movies, whatever helps to reduce your stress. You need to do it because psoriasis is a lifelong thing. And so there are times when the disease will be active, there are times when you go into remission. So you need to know what works best for you and always learn to follow your health provider's recommendations. Thank you.
So thank you, Professor Odibe. So I'll be talking now about what we're doing. Okay, so should I, Dr. Okay. Dr. Cole Adife. Okay, thank you. So can you put on slideshow? Okay, so just go on move. I'm Professor Olushola Ayonlowo, have been introduced, and thank you for being with us on this committee. Just move on, webinar. So I'll be speaking to what we're doing and our project that we're doing on psoriasis. So in 2016, WHO declared psoriasis as an NCD at its 67th World Health Assembly. And some of the barriers that were noted to affect the quality of care and the quality of life of the patient includes limited knowledge, public knowledge. And so in that same year, so some of the actionable steps include patient education and training of healthcare providers, and to address low awareness, misperceptions, and stigma. And then generally, we know that in this environment, by the time you have anything on your skin that appears to be unusual, and people don't think it is just an inflammation like they will call a LAO or any other thing, they just believe it's leprosy, so it's quite stigmatized. So we need to, we hope that at the end of this work, we need to have early diagnosis, appropriate treatment, and enhance our patients' quality of life. Next slide. And so the objective was to establish an online and in-person support group. They can have psychological support. Sometimes when you know that somebody else is going through what you're going through, it just helps you. Can you go back, please? It just helps you. Okay, I remember I had a patient a young man who just had about 15% affection of the body and wanted to commit suicide. And then just met another patient, an elderly man who has an ectodermal psoriasis, come into the clinic. I was even thankful that the thing has calmed down a bit and is less itchy. So, and then they just spoke to themselves, and the other man became better. And then we hope also to empower patients to take charge of their health. And then we hope to train nurses as patient counselors. So there are some information that the nurses need to teach patients. So part of our task shifting, task sharing, so this is not just about the dermatologists alone. We know that as dermatologists, we are not the first frontline doctors. People just refer to us. And so we want everybody to know about psoriasis, the patients to know, the nurses to know, our colleagues, the family physicians, general practitioners, the pharmacists, the community pharmacists to know about psoriasis that can refer appropriately before it becomes chronic. And then and the limit is spread. So we also hope to educate not just the healthcare professionals, to even the general public, including the caregivers, the family, to it is. And we know it's not non-contagious. So it's important the public know about psoriasis. Next slide. And then we also working on our psoriasis registry. We know that research drives improvement in medicine. So up till now, Nigeria and many African countries does not feature prominently on what is known generally, both the clinical and genetic work on psoriasis. And then, so we hope to fill that gap with our psoriasis registry. So we want to encourage our colleagues to please join us and encourage your patient to be part of the registry. We know that with the experience with hypertension that treatment may be different in our Black skin. So we know that up till the point where we started doing work, actually, I do some of these researches in Africa. Hypertension used to be managed with ACE inhibitors like they do in the Caucasians, but we now, after some work has been done, we now know that for our hypertension in Africa, it's calcium blockers and diuretic. So we know that our genetic makeup is different. And even knowing what is it that is causing psoriasis in Africans or preventing us from having a lot of psoriasis would help the global picture. So this, it is important that as colleagues that you please join us with this spring study, and you can DM me later to know how you can be part of the study. Next slide. So this is our overall objectives, to be able to do clinical, epidemiological, and biochemical study, as well as genetic study in our psoriasis patient. Next slide. So we did a preliminary report at the Gene to Clinic conference in December, and we've been able to be part of become part of the Global Psoriasis Atlas now. So coming from this year, we hope that our data will be part of what is the global knowledge on psoriasis in Africa. So I'd like to thank the NAD ESCO for supporting us in our work with psoriasis, the webinar committee, our colleagues, and the ILDS, who has granted us to be able to do a lot of patient education. Then our patient and patient advocates, we want to appreciate them, and the family of the carers. My appreciation is also to the other health workers, medical practitioners, medical officers, pharmacists, nurses, and every other person meeting patients with psoriasis. We do expect and we hope that you would refer your patients to us when you think that you've been struggling with them, and not just keep them with you with triple action therapy alone and antifungals. So many times when you've used antifungal, you've used all those things, they don't work. It's psoriasis. It might be psoriasis. So that we can do early and prompt diagnosis. Thank you all. So I'd like to take questions for us. So we can start dropping our questions. Okay, so before I go on, I forgot to mention that we have started working on the psoriasis support group for the whole of the country. We know that there's a couple of patients are quite interested and enthusiastic, and we know that some of the patients are forming a WhatsApp group. So we want to be able to, we are to, in the next couple of weeks and months, to working on having the National Psoriasis support group and then the psoriasis advocates. We're working on with some of our psoriasis patients to be able to get the support group, and we'll be able to do the physical and online meetings, and particularly towards the psoriasis day on the October 29th. I want to thank you all. Okay, so please, if you're one of the speakers, can we put in our email address into the chats for people that would like to talk to us? So I'd like to take the questions on psoriasis. So any question? Okay. Any question for any of our speakers? So somebody says, this looks like what we call cro-cro. So most likely it's one of our patients and are with us. So what is the common differential? So how do we differentiate psoriasis with any other skin problem? So the word cro-cro is a general statement that people used to call any skin problem. And like just, one of the presenters, Dr. Cole or Dr. Ibekwe, should please answer that question for us. Okay, so I'm looking at Daniel. What is the best treatment for psoriasis? This is by Dr. Chika Emeka. Okay. So Professor Okuzike Odibe will take that question. So can we have, okay, so there's another question that says that what is the differentiation between psoriasis and vulvar cancer? Okay, so any of the presenters can do that. Professor Otike Odibe, Dr. Folakemi Cole Adefe, and Dr. Ibekwe, can we attend to those questions? Okay.
Good evening, everyone, once again. Thank you very much for the question. Yes, I think crocro is a general term that is used for skin lesions and skin rashes in our local dialects and things. So I'm not sure that crocro is limited to just psoriasis. I know that even scabies is often called crocro and even atopic dermatitis. So I think crocro just is a term for itchy, scaly rashes that, tend to come all over the body. And that's one reason. And the skin has very limited ways in which it reacts or responds. So we find that to the layman, it may be difficult to distinguish between various skin lesions. But with psoriasis, it has specific parts of the body that are involved. Usually you have it on the extensor, like the elbows, the knees, the back, the scalp. So the location and the distribution of the lesion, and then some specific features like distinct plaques can help us to distinguish between the psoriasis on one hand, or atopic dermatitis on the other hand, scabies, on the other hand. And then crocro tends to refer to an itchy rash. And psoriasis, while it tends to be itchy, it's not the itchiest. There are things that are more pruritic or itchy than psoriasis, like scabies and atopic dermatitis. So yes, to the layman, everything might look like crocro, but to the trained eye, we're able to distinguish between the various causes of crocro in quotes. So that would be my response to that question. So if you ever see anybody that has crocro, please send them to the dermatologist for proper evaluation of their skin concerns. Thank you.
Okay. One of the questions I have, what is the best treatment for psoriasis? As I said in that algorithm I showed, that psoriasis, there is topical treatment for psoriasis, there is systemic treatment for psoriasis, and there is light treatment for psoriasis. So depending on the affectation of the body surface area, it can be severe psoriasis when it's more than 30%, when it's greater than 10% is moderate, and when it's less than 10 is mild. If it's mild psoriasis, we expect that the patient uses topical therapy and or phototherapy altogether. If it is moderate or severe, we expect that the person should use both the systemic and the phototherapy and even the topical. So it actually depends on the stage of the psoriasis the person is, and that will make you decide on what treatment to use. And when you are using treatment, you take what works for both the patient and what the medical doctor also feels is suitable for the patient. So it's you add treatments together, you combine, and you watch and see. If there is no improvement, you move to another type of treatment. So that's what I can say about treatment. It's not specific. You look at your patient and you decide, depending on the percentage of involvement, what works best for your patient. Thank you. Then there's another question here talking about vulva and vulva cancer and then psoriasis. The only kind of psoriasis that will look a bit like vulva cancer might be inverse psoriasis, in which you have psoriasis around the groin area. And it will be erythematous reddish, and it might not be as flaky or as scale-like as the rest of the body because the area is moist. So what happens in such a place that you also have lesions, if it's inverse psoriasis, you also have lesions in other areas underneath the breast, the armpit, the navel, and in the intergluteal cleft as well. If you see all that, most likely it is inverse psoriasis. If it's inverse psoriasis. If we are not too sure, you see a dermatologist and a biopsy will be done so that the correct diagnosis will be made. There's also another question I saw, I think, on what again? PUVA. Is PUVA available in Nigeria? PUFA is not available in most government hospitals, but some private hospitals in Lagos and maybe Abuja might have PUFA. We also have what we call narrowband ultraviolet, the narrowband, which is available, I know, in teaching hospital in Abuja. So I think those are all my questions, I think. Thank you.
Professor Otikodibe and Dr. Koladefe. Any other questions for the speaker? So just to say that some of our colleagues have done some fantastic reels. The part of the public awareness and I've put up some of the links in the chat box. Somebody said, what are the causes of? Somebody is asking a question. What are the causes of? This question is not specific. Causes of what? Is it psoriasis or what exactly are you talking about? So then somebody asked a question on the role of hydroxyurea and the drug you mentioned it. The person said, I did not hear you very well. Aliyu Abdullahi said he didn't hear very well, so he wanted to look at the role of hydroxyurea and the other drug, another drug.
Okay, hydroxyurea and thioguanine, antimetabolites, just like methotrexate, and they work by reducing the buildup of the cells, and so causing the slowing down of the cells, the production of the cells in psoriasis. So they can be used as well for psoriasis. They're not common things we use here because we have other options before we get to them, but they can also be used.
So there's somebody who has one, Lara Rufai, what are the causes of it, psoriasis? So obviously, she probably was not there when we're talking about.
At
So
the
I'll just like,
beginning, yes.
yes, to just give a 1 minute answer to that question.
Yes, ma'am. We also have some questions on the YouTube live that I would love to also address because we have an audience on YouTube as well watching. So I'd like to read out the questions from YouTube. So Akunwane Stephanie is asking, please, what could trigger psoriasis? So I would go over that again. Motolani Akimbo is saying, please, the speaker said lack of social integration, depression, and anxiety causes psoriasis. Please, can he explain how? Then Babatunde Bosede is saying, I would like to ask if psoriasis medications interfere with a woman's fertility. So those are the questions we have from YouTube as well. And some people are asking for the slides, but the slides may not be available, but the link, this webinar will be on our YouTube page if you would like to rewatch it. So I would just quickly go about the trigger and the causes of psoriasis. We mentioned earlier that the exact cause is not fully understood, but it's known to be as a result of a complex interplay. Can you hear me, please?
Yes.
It's known to be as a result of a complex interplay of genetic factors. So some people have genetic predisposition to psoriasis. They have some inherited genes that make them more at risk of psoriasis than others. And then there are environmental factors that can, if the person has the genetic risk, these environmental factors can trigger the development of psoriasis. Things like the change of weather, things like infections, trauma, medications. Some people with a genetic risk their psoriasis can be triggered by some of these things. And then you also have the immune dysregulation or immune dysfunction. Our immune system is meant to work and control foreign bodies, remove old cells, and it has a function in it. But sometimes the immune system begins to overreact to things that is not meant to react to and cause reactions that can lead to skin rashes like psoriasis. So those are the three main factors that have been associated with it. We can't pinpoint an exact cause per se, but we have these causative factors that come together to increase one's risk of developing psoriasis. Now, the other thing is, somebody was asking about the triggers. So I think I would allow Prof. Otikodibi to talk about the medications, whether it interferes with fertility. And then somebody spoke about social integration, depression, and anxiety as well. I think that is actually a result of psoriasis, not a cause. So if one has psoriasis, what the speaker mentioned was that the stigma can lead to lack of social integration, depression, and anxiety because of the way people stigmatize skin conditions. So it's not that those things cause psoriasis, but psoriasis can lead to those adverse effects.
Thank you, Professor Otike-Odibe. Any question?
Okay. Yes.
Comments?
Yes. There's a comment on if the drugs are safe for pregnancy. Yes, some of the drugs are not safe at all for pregnancy. Like retinoids, isotretinoin cannot be used by a woman that is pregnant or wants to get pregnant soon. Methotrexate cannot be used. Some biologics also cannot be used because there's limited data on the study of what they can do for pregnant women and lactating women, and cyclosporine. This data is limited. But there are several options that can be used for a pregnant woman, like topical steroids, at least can be used, and maybe some biologics if you really look at it. I would just advise any pregnant lady or anybody that wants to get pregnant to let her doctor know so that several options can be considered and researched for that particular patient.
Thank you, Prof. There's a couple of questions in the chat box. Dr. Edutimi Perez says that thanks, professors and colleagues, for a wonderful presentation. Since psoriasis is a multi-systemic disease, just like RA, will it be justifiable to commence DMAT irrespective of the severity? And then I would answer that. Okay, so there are some patients, they might have mild psoriasis, but we call some presentation as high impact psoriasis. For example, if you have psoriasis on your face, you have it in the scalp, you have it in the groin. So patients really take very seriously. So you call them high impact areas. And those conditions, we can even start the biologists immediately. Actually, it's because biologics are expensive. That's why we're not really starting them early in Nigeria. They're not even on our insurance. So and then patients, some people, they can afford it and they want to start at the high end. We can start them on the high end. So treatment of psoriasis is so individualized per patient. Even some patients will tell you straight away that they don't even want anything systemic. Let me just be using my topical. Even if it doesn't go, let's just look nice a little, not scaly, and they're okay with it. Whereas somebody with the tiniest is bothered about it. So we sometimes the treatment is actually a conversation between the physician and the patient. I don't know if I have answered that question. Okay, so there's another comment here. It's a question or comment. Then Dr. Lash, okay, so it's been said. Okay, so the question is just to thank NAD for this program. So I don't know whether there's any other question. Can you help me check with people online? I'm trying to look at it. I don't think I can see any other question from our online participants. So I'll hand over to the I'd like to thank you all once more for being part of this community.
Sorry, Ma, can I just draw us back? We have the YouTube channel and I'm seeing some comments there. I don't know whether we're taking them.
We have taken them, Dr. Hawa.
Okay, no problem.
Yeah, I've taken them.
Okay,
I think there are new ones. I think we've taken all of them. So I'd like to hand over to the NAD Scientific Committee Chair, Professor Akikube, to take on from me. Thank you.
Okay, thank you very much, Professor Anyolowo, and all the speakers for a wonderful session. It's generated a lot of questions, and I can certainly say it's been demystified. I don't think there are any announcements, so we'd just like to thank our participants from different realms of the healthcare space. You have the contacts of Professor Yolowa for the registry and any other details you may have. And on this note, I'd like to thank you all and wish you a good evening, and we'll see you next month. Our webinar will be on the last Thursday of September. Mr. President, any announcements or Hawa?
I don't know whether it's
yes.
okay.
I think, are you sure the webinar will hold next month? Because we have the Skin Alliance. It's that same week, unless it's going to be earlier than that. Because
Okay, we'll discuss it on the webinar committee and take a decision.
Well, people will take the decision. But people will still be in transit that Thursday.
We'll either host it. We'll talk about it on the webinar committee and take a decision, but we won't hold it obviously on that day if it is the last Thursday.
Okay.
But we'll discuss that internally.